Good day. I'm Dr. Bellinger, Drake Bellinger, and I'm here to discuss all aspects of the weight loss surgical options that we have here at our office. A little bit about myself. I'm a board-certified surgeon. I've been doing weight loss surgery since my early training. So back in my residency training, when I was training to be a surgeon, I began performing weight loss surgery then. I was a general surgeon, and then in 2004, I gave up all the other aspects of a general surgery practice, and I committed myself to purely becoming a bariatric surgeon. So since 2004, the only operations I perform are bariatric procedures. Our office is designed, because we only do weight loss surgery, our office is designed to answer all questions that a weight loss surgery patient might have. It is also designed to make sure that the weight loss surgery patient is taken care of from the time they enter the office to the time they leave, both before and after surgery, as well as for the lifetime of that patient whenever they want to come back to see us. We also have a nutritionist here, so our whole program, what encompasses the program is a nutritionist to give our patients nutrition counseling. We also have support groups we have that meet on a weekly basis, both in Baton Rouge as well as Gonzales, to offer support for our patients, someone to lean on, someone to give recommendations to as well. And then we have our office here, our physician assistant, Holly Edmonds, will be able to answer a lot of patients' questions whenever they do call in. So everybody here in the office has a place in helping the weight loss surgery patient achieve their success. And when you have weight loss surgery, I'm sure a lot of people may have asked you, why do you want to have surgery to lose weight? You may even had a health professional, a doctor, say, why do you want to have surgery to lose weight? And we never want it to be the only thing that a person tries or the first thing someone tries to lose weight, but we do think it should be offered to patients if they failed all the other methods. The science behind that is that if a person has tried at least 3 other good diet programs, we feel that they're a candidate for weight loss surgery. So when you look at weight loss options, first off, you have diet programs. Diet programs in the patients who are candidates for weight loss surgery, so that's 70 pounds or more overweight, those patients are about 10% successful in the long term. Also, when you look at that, it's usually going to have been within the first 3 diets that they try. So if a person has tried at least 3 diet programs, have failed those diet programs, meaning that they've gained their weight back, because most people are able to lose the weight, it's maintaining the weight that's a problem, we feel that they're an appropriate candidate at that point in time for weight loss surgery. And that's where we think it's appropriate to offer patients or people weight loss surgery as an option to maintain their weight forever. And like I said earlier, diet programs are about 10% successful in the population we're performing weight loss surgery on. When you look at weight loss surgery, it's not 100% successful. It's 80% successful, but it's not 100%. We wish it could be 100%, which is why we do not only the surgery, but we do it in the context of a program. So we feel that if we can get it closer to or higher than 80%, we'd love that. But when you look at the national statistics, the weight loss surgeries are about 80% successful, getting patients to lose their weight, but not only lose the weight, keep that weight off for a period at least 5 years or more. So we want it to be for a lifetime, but we're gauging it about at a 5-year level. When you look at operations, operations perform 2 different ways. There's the traditional method, which is done by performing an incision and having the patient use his eyes and his hands to perform the operation. We perform our operations preferentially with the laparoscopic method. So the way we do it is we make 6 little small incisions on the patient's abdomen, and we use skinny little instruments and a video camera that's very slender to act as our eyes. So the video camera is our eyes, and the thin instruments that we use are our hands, and we're able to perform the same operation we would have otherwise done in the traditional method. We're now doing it with the aid of these instrumentations laparoscopically. And there are several advantages to that. The main advantage, obviously, is scarring. There's much less scarring having the small incisions rather than the bigger incision, and obviously there's a lot less pain involved with that. Added to that, patients are able to get back to doing what they normally do in their normal lifestyles much quicker after laparoscopic surgery than it is after open surgery. So driving, office work, getting back to doing whatever you normally do in your normal daily activities, you're able to do it quicker with the laparoscopic method. But these are operations, so we never want to minimize the effects of an operation or the seriousness of an operation. Operations are serious, and all operations have their risks. So the next thing I'd like to cover now are the risks of the procedure. So when you look at the risk, I like to break them down into two different methods. One are the general risks. So these are general risks that are common to all operations, whether it be a gallbladder operations, a hysterectomy, or operating on someone's intestines. There are certain risks that are involved in surgery. So first off, the general risks that are involved with surgery. Bleeding, possibly requiring a transfusion, infections, injury to the internal organs are a possibility, the spleen, the liver, the intestines. Those are all possibilities, although that's pretty rare. Pneumonia is a risk of surgery, and although pneumonia involves the lungs, not the abdomen, there is a risk associated with surgery because incisions cause pain. Pain causes people to take less of a deep breath, and if you take less of a deep breath, you have potential to develop pneumonia. Obviously, this is much less with the laparoscopic method than it was with the traditional older method because of much more pain. But we still list it there because it is a slight possibility. We also have heart problems there, mainly because most of the patients coming to see us have diseases that are associated with their weight, such as high blood pressure, diabetes, high cholesterol. There is a conceivable possibility that a patient may have a hidden heart problem. So if you should have a heart problem, we want to make sure we detect it before the operation. So one of the things that we do in our office to make sure that all patients before undergoing anesthesia are cleared by a medical doctor before proceeding on with the surgery. And that's why we want to make sure that if there is a heart condition or a medical condition that should be addressed first prior to surgery, it's dealt with before. With these weight loss operations, all of them, there's a possibility for weight regain. Like I said earlier, 80% of the patients are successful, but there are 20% of patients who gain some of their weight back. So that's a possibility with the weight loss operation. Depression, most of the time, 9 out of 10 times, depression gets better after weight loss surgery. But on occasions, after the operation, there may be some emotional challenges that the patient has regarding food or the lack of their relationship that they used to have with food. We have the appropriate individuals to refer the patient to if that should become a problem. Gallstones, anytime someone loses weight rapidly, there's a possibility of developing gallstones and having a gallbladder problem. Redundant skin is a possibility after weight loss surgery if you lose a lot of weight, depending upon the nature of your skin. There may be some skin issues long term after that. Blood clots, a very serious complication after any type of operation. We do several maneuvers to help minimize that. We give blood thinners, weak blood thinners, as well as these compression stockings on a patient's leg at the time of their operation to help minimize that risk, but that is one of the risks involved with surgery. And obviously death, dying from a procedure. All operations have that possibility. It's fairly low with this operation being less than 1%, but these are major operations, so we want to make sure people understand that there can be serious complications, although it's pretty rare. Now the next thing I'd like to do is go through each specific operation that has its own set of side effects associated with it. First one I'd like to take is the gastric bypass. The gastric bypass is the most involved procedure. And because it's the most involved procedure, the risks are slightly higher in that operation than with the other ones. So if you look at the risk of the gastric bypass, there is a possibility of a leak. That's a very serious complication. If that happens, it has to be surgically repaired, and usually occurs within the first 12 to 24 hours after surgery. Stricture is a possibility, and what that is a narrowing between the stomach and the intestines where we make the connection between the two of them. If that should narrow to the point where the person cannot tolerate solid foods, there's a small procedure that doesn't involve any incisions or cuts at all where we can stretch that open or back open. Bowel obstruction can occur for years even after the operation. It's common with any operation that involves the intestines. It's pretty rare. It happens about 4% of the time, but if it should occur, that does require an operation to repair that. Vitamin deficiencies can occur very commonly after gastric bypass, but if you take the vitamin regimen we recommend, it's fairly low likelihood that happens, but it's very, very, very important for a gastric bypass patient to remember to take their vitamins after the operation because you can get vitamin deficient. Ulcers. Patients after a gastric bypass are very sensitive to certain medications as well as smoking. So we discourage smoking because smoking can cause ulcers, but medications such as Advil, ibuprofen, Motrin, all those that are in that class of medication can cause ulcers in these gastric bypass patients. So we recommend that you avoid those medications, or if you have to take them for bone or joint issues, that you protect your stomach with a medication that protects your stomach or reduces stomach acid at the same time. Gastric distension is a very rare complication where we might have to put a tube in the remaining or the excluded part of the stomach after the operation, although that's extremely rare. And there's a risk of pouch dilation, or if the patient starts to regain their weight, there's a possibility it's because the opening has gotten too large between the pouch and the intestines. The next operation I want to go over the wrist is the gastric banding operation. So the gastric banding is an operation that's performed by placing a silastic belt around the stomach, so to speak, and when we buckle it into place, it limits the amount of food you could take in. So the risks that are common with this operation, because it's being put around the stomach, there is the risk of stomach injury, although that's pretty small. But because the banding operation involves a foreign body, there is a risk that that foreign body may move or not be tolerated so well by the body. So when you look at the risk involved with the banding procedure, it's related to the fact that there's a foreign body there. So if you look at it, one of the things is erosion or an ulceration in the stomach. If that should happen, the band has to be removed and it can't be placed back in. Also slippage. The band can slip or move down the stomach or alter its preferred location. If that happens, the band has to be surgically repositioned and sutured back into the proper position. Port malfunction is a possibility. If that happens, most of the time we're able to just switch over to a thicker liquid, but on rare occasions the port may have to be removed or replaced. Pouch dilation is another potential problem with the banding operation. It occurs whenever the stomach or the esophagus just loses its muscular function and it doesn't pass food down past the band adequately. If that happens, we have to remove all the fluid out of the bands, and on rare occasions it does require the band to have to be removed. The last procedure I'd like to go over is the vertical sleeve gastrectomy. This operation involves cutting a portion of the stomach out. So when you look at the risks that are involved with that operation, there is a possibility for a leak, although that's pretty rare. There's also a possibility of a stricture or a tight area which can impede the flow of food through the stomach. That's pretty rare as well. There's also, because we are removing a portion of the stomach, the operation is irreversible, meaning that once we remove that portion of the stomach, it can't be replaced. Now, we don't look at that as a bad thing because we're doing a permanent procedure for a permanent problem, the person's weight problem. There's a possibility for a sleeve dilation or the sleeve getting larger, although that's pretty rare, and it usually doesn't get any larger to an appreciable degree. There's a risk of reflux or gastroesophageal reflux disease. It's pretty rare in our experience, but if you do happen to have that, we can put the patient on medications for that. The other thing is that it's, if you research this operation on various modes, especially the internet, you may see that there's a possibility for a second operation. That's because the operation was discovered as part of a two-staged operation, meaning that the sleeve gastrectomy was half of a bypass procedure. We're not using this operation as a double procedure. We're actually using this as a primary procedure, meaning we're making our sleeve operation small enough where it should be able to stand on its own, so we have no intention on there being a second procedure with this operation. The next thing I'd like to do is to go over the operations that we perform. We perform 3 different operations: the gastric bypass, the laparoscopic adjustable banding procedure, as well as the vertical sleeve gastrectomy. First, if you look, we've provided some animation for you to look at as well in each different procedure. So if you look first at the gastric bypass, I've drawn the normal anatomy. So this is what our normal anatomy looks like. We have the stomach. This is your esophagus, which goes from your mouth to your stomach. And then you have your intestines, which go from your stomach down throughout your abdominal cavity, and it ends in your colon and then out. First, I'll describe how we do the gastric bypass. So if this is your normal anatomy, the way we do the gastric bypass, and I'll draw it out here, is First, we have to make your stomach smaller. So one of the ways you lose weight after gastric bypass is making the stomach smaller. So we do that first. And the way we do this is we divide the stomach as such. So we make a small little stomach pouch up high and exclude it from the rest of the stomach that's lower. And that, with that maneuver, we've made your stomach pouch, or the new stomach, about the size of a large egg. But as you can see, we need to make a passageway for food to get down to the intestines. So what we do now is we go down to your intestines here and we divide it in half. And what we're able to do is we take the downstream end of your intestines and we bring it up here and we provide and we perform what we call an anastomosis. And what that requires is us to make a small hole in the little stomach pouch and attaching the intestines to it, so now it looks more like this. And then you have this connection between the intestines and the stomach. And then we come down here to where the two pieces of intestines are lying next to each other. We make a small hole in this piece of intestine here, and we connect these two together as such. So this forms a Y, which is why it's called the RNY, the Roux-en-Y gastric bypass. So the way you lose weight with this operation is, first, we've made your stomach much smaller. Because we've made your stomach about the size of a large egg, you can't eat as much. So that's the first method we make you lose weight, or we have you lose weight, is by the restrictive method, meaning that you can't, or you're restricted from eating as much food because we've made your stomach smaller. The second reason is a malabsorption. Because now your food travels down this way and your digestive juices go this way, they're separated for a period of time. Once they combine here at the Y, you're able to digest these foods and these calories, and you'll be able to absorb them. But because we've short-circuited the intestines, so to speak, you're not able to absorb all the calories. So that's the other method how you lose weight after gastric bypass, and it's called malabsorption. But probably one of the most important reasons why people lose weight after gastric bypass is because of this area of the stomach and the process by which the food is circumvented around this area as well as introduced early on into the intestines. And what you see with this is that because this area of the stomach looks for food as a trigger to produce these chemicals that your body normally produces, it's lost its trigger. So what happens is after gastric bypass, patients notice where they're not as hungry because it's altered the ability of the stomach to make a certain hunger hormone, but it also causes your body to use fat and sugars in a different way. And this is very important for diabetic patients. Because we've rerouted this and because of the way food is now introduced differently into your stomach as well as the intestines, your stomach and your pancreas begin to communicate with each other, and what happens is the chemicals cause a reversal in diabetes. So it causes your blood sugars to lower, it causes your body to more efficiently use those blood sugars, as well as using fat as an energy source. So patients after a gastric bypass will lose weight faster than what you would normally expect had they been on the same diet and not had the gastric bypass. So that's probably the most important reason why patients lose weight successfully after gastric bypass, and that's the biochemical method, or the biochemical reasons why patients lose weight. The next operation I'd like to discuss is the adjustable gastric banding operation. So when you look at the adjustable gastric banding operation, it takes a silastic band and it places it around the stomach. So I have here in my pocket what one of these bands look like. So if you look at it, it comes to us separated like this. So it's like a belt. So when you put a belt around your waist and you buckle it into position, that's how we do it around the stomach. So we have to make a small little tunnel behind the stomach, pass the band around the stomach, and buckle it into position. The band is also attached to this tubing and this port. So if you look at it after the band's in place, if this is your stomach, the band squeezes on the top portion of the stomach. You have this little tubing and this port. Now the port is positioned underneath your skin but sewn to your stomach muscles. So you can't feel it, you can't see it in any way, but we're able to feel it here in the office, or if we have to, we can always go to a radiology suite and we can identify it on x-ray, and we could place a needle into the gel portion of this port and add fluid to it. And what the fluid does, it makes the balloon on the band full of fluid and thereby compresses on the stomach, making the opening in the stomach smaller. So if you look at it, the band is here around the stomach, and what we're doing is we're manipulating this little opening in the stomach. Now the band is a device meant to affect how much you're able to eat. So what we recommend to our patients is you must eat solid foods. So solid foods, when you do eat it, it'll come down here and it'll stop by the band. And what I like to refer to it as sort of a speed bump for food. It slows the food down long enough so it can fill up the very top portion of your stomach. If it does that, your body doesn't know the difference between filling up and stretching the top portion of the stomach versus filling up the whole stomach. What we're wanting our patients to do is eat over a longer period of time, say about 40 minutes or so, in order for that signal to be sent to the brain so that it shuts off the hunger response. So with the band, you must utilize it as a tool, like with all the operations. Eat solid foods. We want to avoid liquid calories because it isn't designed to stop liquids from going past the band, only solids. So we want a person eating solid foods, a very healthy diet, and using the band as a tool to help with your hunger and help with being full. And what happens is because you're using the band as a tool, you'll eat less calories. Less calories will mean weight loss. So when you look at this operation, the weight loss occurs over a period of about 2 to 3 years, as opposed to, say, like the gastric bypass, which causes patients to lose weight over a year, year and a half, or the sleeve, which causes patients to lose weight over a year, year and a half. So that's how the gastric banding is done. Now this port here is being, most of the time we're able to access it here in the office. So one of the things we do with our patients is close follow-up. And we want to talk to you, see how you're responding to food, making sure you're eating solid foods, healthy foods, and if you need adjustments, we make an adjustment. If we don't, we just continue to monitor you. The last operation I'd like to talk about is the vertical sleeve gastrectomy. And it's called a sleeve operation, but we don't put anything around or inside the stomach. It basically refers to the fact that when we do the operation, we make your stomach long and slender like the sleeve on a shirt. So it actually involves removing a portion of the stomach. So likewise, when I showed earlier what the normal anatomy looks like and what the normal stomach looks like, it looks like this. With the sleeve operation, one of the things we do, we go in first, and there's a muscle which marks the end of the stomach. That muscle is very important. What happens is, when we all eat, that muscle closes off, and it's designed to keep food inside the stomach long enough to be liquefied. And then your stomach's a muscle, so it then pushes the food out of the stomach once it's become liquefied, and your intestines are able to digest it at that point. So that's important for us, that muscle. It's called the pylorus. So if we look at that pylorus and we're able to feel and tell where that pylorus is, we measure back about 1.5 inches away from that muscle. And that's when we start the operation. So basically what we do is, on the outer edge and on the inner edge of the stomach, we all have blood vessels, and that's how the stomach gets its blood supply, from little vessels coming from either side. We're not necessarily worried about the inner part, but this outer part, first thing we have to do is seal off those blood vessels just to free up that edge of the stomach. Once we do that, we're able to take a device that clamps on the stomach, and it's the same device we use to separate the little small stomach pouch in the gastric bypass. It's a stapling device, but the staples are approximately 2 millimeters in length, so they're very small, and when we're done with it, it cuts and seals the intestines and or stomach, and it almost looks as if someone had taken a sewing machine and sealed off the edge of the stomach. So we use that device, and what we're able to do is we're able to tell how much stomach we're leaving because we use a tube called a bougie, and you may hear about that when you do some research on the internet. That bougie is placed by the anesthesiologist while you're asleep, and is of a certain size, roughly about the size of my index finger. And we use that as a guide or a template. So we're able to place our stapler on the outside of that and go up the stomach, and what we're able to do is seal and cut the stomach, so once we're finished with the operation, rather than the stomach being bulbous and larger like this, it is much smaller like this. And we have that animation that you can see as well. So what we're left with is a stomach that looks like this. And that represents about an 80% reduction in the stomach. So we remove about 80% of the stomach. So one of the ways you lose weight after the vertical sleeve operation is the fact that we've reduced the size of your stomach. So you'll only be able to eat 20% of the food that you once did before because of the smaller size of your stomach. But probably one of the most important things about this operation is the area of the stomach that we removed. Like I stated earlier with the gastric bypass, that area of the stomach is responsible for producing chemicals. And what we see, because we've removed that portion, there's a very strong response for the patient's hunger or lack thereof. So because we're removing that section of the stomach that's primarily responsible for producing a very strong hunger hormone, person is less hungry. So we take advantage of that. So not only do we have a restriction component, we also have the hormonal or the biochemical component. Likewise, just like with the gastric bypass, we've seen that our diabetic patients begin to normalize with their blood sugars. So your body starts to use blood sugars more appropriately. Diabetics have a reversal in their diabetes immediately after the operation, even before they start losing weight. And your body starts to use fat primarily as an energy source, so those patients as well will likely lose weight faster than what would normally be considered normal after eating the similar amount of food. Like the gastric bypass, the sleeve operation also has weight loss occurring over about a year, year and a half. Now that we've finished discussing how we do the operations and any of the risks that are involved with the procedures as well, I'd like to discuss a little bit about our office process. So one of the things we're going to have done is when you do come here, the first thing we'll do is we'll have a one-on-one consultation. At that time you'll be able to discuss personal issues, your medical conditions, or anything that would need to be addressed before your operation. The second thing we'll do is we'll get you scheduled for a few different office visits or different visits to different individuals. First one's going to be to the psychologist. All of our patients see a psychologist beforehand, and we'll schedule you for that visit as well. One of the other things we do is we'll schedule you for a visit with the nutritionist to go and sit down and discuss how your eating is going to change right after the operation, as well as lifelong and what's going to go on with that. You'll also have a visit with other personnel and testing done at the hospital. And one of the last visits will be with the medical doctor who's assigned to evaluate all of our patients to make sure that they're cleared for surgery and it's safe to proceed with anesthesia for their procedures. Now that you're finished watching this informational seminar, if you're interested or you have any questions that you'd have for anyone in our office, you could contact us through our website, and that's weightlossbr.com or weightloss-la.com. And under the Contact Us tab, you can request some information via email, or if you would like, you can schedule an appointment, or if you have some questions, you can ask one of our personnel, and that's going to be area code 225-743-2333. Thank you.